This is TTT Live. I'm DK Roster. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, Sweet 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning and welcome to another Ministry of Health virtual media conference which provides you with information on the Ministry's COVID-19 response. Today we have with us the Honorable Terence Dayal Singh, Minister of Health, Dr. Avery Hines, Technical Director of the Epidemiology Division, and Dr. Hazel Othello, Director of Mental Health. I am Candice Alcantara, Manager of Corporate Communication at the Ministry of Health, and I will be your moderator this morning. I invite the Minister of Health to make the opening presentation.
Thank you very much, Candice. Good morning to Dr. Hines, and good morning to Dr. Hazel Othello. As we thought it prudent to invite Dr. Othello this morning to talk about the issues pertaining to mental health, given what is happening with COVID and the type of occasion that will be recognized this week between today and tomorrow. Good morning to ladies and gentlemen of the media and the listening and viewing public on this Wednesday morning, Wednesday the 9th of September. It is my intention this morning to deal briefly with two important issues. One is to follow up on what was mentioned here on Monday about two of the drivers that are really giving us sleepless nights in this second phase. I would have mentioned them both. This morning I want to focus on one, and that has to do with the ill persons going to work, either knowing that they are ill and the responsibility of businesses to follow guidelines. We had put out these guidelines in May of 2020. May of 2020. May was the 5th month. We are now into the 9th month. So these guidelines have been in circulation now for 4 months. These are not new guidelines. They were sent out to all chambers and so on. And the guidelines spoke to the new normal and the reopening guidelines for businesses, facilities, and institutions. And it talked about, on page 7, who the key stakeholders are. And I just want to quote, these guidelines directly apply to all businesses, facilities, institutions, both private and public, across Trinidad and Tobago, including but not limited to groceries and supermarkets, stores, churches, banks, homes for the aged, offices, schools, public and state sector agencies. It is not my intention to go into all the details, but the guidelines speak to the fact that we must not encourage knowingly, and you could institute measures like thermal screening to ensure that persons who are febrile with fevers, which is a sign of a respiratory illness. It's a good screen. It's not a foolproof, but it's a good screen. Don't come into your work and infect your entire workforces. What I would like to do this morning is employers, we need to recognize several things. This global pandemic is not slowing down. There are now 27,791,319 cases worldwide. The average number of cases per day continues to hover between 275 to 300,000 cases per day. The number of deaths, and we have seen our deaths go up, regrettably, but it's still well below global averages. But these are people with real families, with real names. No, we say 30-something people have died, but these are real people. Real families are hurting. These are not they may be nameless individuals to us, but those those families affected, they represent a father, a mother, a sister, a brother, a loved one. And we have a duty, I think, if it hasn't impacted in the psyche of the population, to protect that most vulnerable group. Because the death toll to date is 903,058. At the current death rate around the world, and it has come down slightly, it's hovering around 5,000, give or take. It is only a matter of time before we reach 1 million deaths worldwide, which will not be a good place to be, but I think it's going to be inevitable. So we are asking employers to familiarize themselves with these guidelines, which we had sent out since May 2020, and asking businesses and employers to do what is right, both for your employees, what is in best interest of your employees, because you want a healthy workforce. You want a workforce that is healthy and happy, that is well protected. A lot of this onus now rests on you. We want your customers and your clients to come to your places of business. We want business activity to pick up. And we want to have business continuity. We don't want to see business shutting down because employees are being allowed to come to work ill. So please avail yourselves to the guidelines. And as I keep saying, there are other guidelines available from many of the consulting firms. There are guidelines put down by CDC, WHO. Avail yourselves of it. This is a very important way to dampen the second wave. I want to now turn to the issue of testing and where we are with some positive developments over the past 48 hours as we continue our objective of decentralizing testing. Now that international supply chains have reopened, are reopening, and more test kits are being made available, there is no longer embargoes and so on. We have in stock 3 types of test kits. The BGI test kits, which we get from China. We currently have 8,000 in stock, and we have an order for 20,000, which will come in October of this year, which is next month. That 20,000, we have invested 2 million TT dollars for those 20,000 test kits. The Abbott system, where we did have challenges getting the kits out of the United States, I'm happy to say we got 8,000 kits ahead of schedule. 2,000 have been sent to NCRHA because they have their own PCR machine. 2,000 have been sent to MRF-TT, which we brought on stream about 2 weeks ago. 1,064 will be sent to the TPHL stores, and this is the positive development. 3,000 have been sent to Southwest Regional Health Authority. So Southwest Regional Health Authority will now have the capacity to do their own PCR testing, I am told, after having a discussion with the officials, hopefully by Friday of this week. The machine has been validated by CARFA. They passed their test panel. They have trained the technicians. We have put the teams in place. So Southwest is going to have a significant ease. Those 8,000 tests would have cost 4.2 million TT dollars, and we have 28,800 coming in October at a cost of 9.3 million TT dollars. The Gene Expert tests, we are exploring more and more avenues for that. I can't give you exact dates and figures on that, but we do have some tests in the country. Antigen testing, I'll give you an update. We now have the cost estimate for the 160,000 tests. They are going to cost us $8.4 million TT. And the antigen testing will be the real game changer for the total decentralization down to point of care. These antigen test kits are now certified by PAHO. We are getting them through PAHO. The technology has improved greatly in the past 2 months, where we can now trust these tests. So in total, for some of the tests that recently came in, the ABBA tests, and all the test kits we have coming in into the country, we are now expending in this phase of purchasing test kits about 23.9 million TT dollars. This investment not only represents an investment in money and test kits, it will really help us with our strategic objective of decentralizing testing. And I'm particularly pleased that Southwest will now have their PCR machine, not the machine up, but everything that is needed. The training done, the consumables here, the test kits here. So those swabs will no longer have to make their way to Port of Spain, to be tested in Port of Spain, and then results sent down to San Fernando. This is going to be a real positive development for San Fernando General Hospital. So ladies and gentlemen, those are the two issues I wanted to raise this morning. Let me just recap briefly. We are urging employers to familiarize themselves with the guidelines that were set out in May of 2020. Dr. Hines will speak to it in more detail. One of the drivers, let me repeat, for the second wave are ill persons in your workforce. That has been proven over and over again. No office in the land, from the highest to the lowest, is immune from this. And I have given you an update on where we are with testing, and we have had some positive developments. So Candace, I want to thank you for the opportunity for the past couple of minutes.
Thank you very much, Minister Dayal Singh. And now we move to Dr. Hines, who will provide us with the clinical update and some additional guidelines for the workforce.
Thank you, Ms. Alcantara. Good morning, Honorable Minister. Good morning to my colleague, Dr. Othello. Good morning to the members of the media, the viewing and the listening public. Today's update for September 9th, 2020 is as follows. The number of samples that were submitted to the UE and CARFA local testing sites for today, up to today, were 25,796, out of which 22,874 are classified as unique patient tests. There are currently 2,493 positives out of that testing system, and there are 1,705 active cases that have been diagnosed and are still considered active at this point in time. To date, there have been 39 deaths, and we extend our condolences to those families, and there have been 749 discharges. You would note that the 102 additional cases which we'll be reporting on for the most recent time period would actually be comprised of two distinct groups of persons. 43 of these were actually persons who were in the police academy and therefore not out and about interacting with the public because they had already been identified as potentially having been exposed. They have been tested and they will be processed according to their clinical symptoms and the clinical requirements. It is also to be noted that out of the 102 positive cases, that group actually corresponds to a time frame of testing that would have occurred between the 29th of August and the 8th of September, so it does not represent just a 24-hour time period. With regard to the clinical update of the patients currently in the health system for COVID-19, there are 103 patients currently hospitalized. In Hoover Hospital, there are 77, with 5 in the ICU and 10 in the HDU. At the Cora Hospital, there are 26. In the step-down facilities or the transition facilities, there are currently 38 individuals, 5 at UE Debe, 32 at UE Freedom Hall, 1 at Napa. And the capacity of these sites in terms of their occupancy is as follows. for the hospitalization side, we are approximately 40% capacity. For the step-down sites, we are at 38% capacity. And with regard to the individuals who are in the suspect ward, that is, individuals awaiting test results but being given clinical care for their respiratory issues as they currently arise, we are at 68 individuals out of 141 spaces, so that's approximately 48%. So this just gives an idea of the current occupancy versus capacity of the parallel health system. The individuals currently in quarantine that would be part of the repatriation process are as follows. We have 14 at the Chancellor site, 19 at the Cascadia site, 26 at Home of Football, 45 at Regent Star, 95 at Paria. So in total, there are 199 persons in that system, which represents approximately 64% of that capacity. That would bring me to the end of the brief laboratory and clinical update. Turn you back over to Ms. Alcantara.
Thank you very much, Dr. Hines. And Dr. Hines has some more information for us as it relates to guidelines for the workforce and employers.
Thank you, Ms. Alcantara. Now, I'm not going to go through the entire New Normal document. This document can be found on the Ministry of Health's website. The section for guidelines is actually quite well demarcated, so I would encourage everyone to reference the document that is lodged there. But as we have noted that ill individuals coming into the workplace happens to be one of the driving factors in the new and ongoing infections, we do want to highlight a few key points. And this is more to do with the relationship between employers and employees than it is to do with the employers and the clients that they may service. We do want to ensure that the physical distancing requirements are maintained, that where office spacing does not allow physical distancing to be maintained with the full complement of staff, that rotations be considered, and that these rotations allow for both continuity and physical spacing that reduces risk. We encourage use of masks in the office space wherever the physical distancing cannot be maintained. We encourage the frequent sanitization of shared items, for example, telephones. While people may feel uncomfortable to sanitize a phone before using it, it is really as a courtesy to others that the phone is being sanitized. You sanitize both before and after. So you're not indicating any particular judgment on whoever used the phone before, but as a routine, sanitizing a shared telephone before and after use should be one of those things that we consider as a norm. Doors being propped open to avoid the need for touching of door handles where possible. Again, we encourage that. And the sanitization and frequent cleaning of shared surfaces in kitchens and bathrooms, places that people may touch surfaces and not necessarily be conscious or aware. Again, we do want to encourage that that process be emphasized to the greatest extent possible. More importantly, if anyone feels unwell, we want to encourage employers to create an environment where individuals do not feel compelled to come to work while they are unwell, which brings with it the danger of infecting others of their colleagues and further reducing the workforce. So we do want to encourage employers to encourage their employees to remain away from the workplace at the first signs of any of the viral illness symptoms that we've been speaking of. The loss of sense of smell, extreme fatigue, the fevers or cough or sore throat, be it ever so mild. We do want to encourage individuals experiencing those symptoms to remain out of that work environment so that we can reduce the risk of infecting the others of your colleagues. I'm going to leave it there for now. If there are additional questions that require clarification, we can always bring those up during the question segment, but I'm going to turn you back over to Ms. Alcantara at this point.
Thank you very much, Dr. Hines. and in recognition of World Suicide Prevention Day, which takes place tomorrow, we will now have a presentation from Dr. Othello.
Good morning, Honorable Minister, Ms. Alcantara, Dr. Hines, and viewers and listeners across Trinidad and Tobago and beyond, as well as our media practitioners. Good morning, all. Since 2003, World Suicide Prevention Day has been observed annually on September 10th. The observance of this day is organized by the International Association for Prevention of Suicide, the IASP, with the World Health Organization as a co-sponsor of the day for the purpose of raising awareness around the world that suicide can be prevented. In 2014, through the first World Suicide Report titled Preventing Suicide, a Global Imperative, the WHO aimed to make suicide prevention a high priority on the public health agenda. Your Ministry of Health recognizes the urgency of suicide prevention and is therefore pleased to join the rest of the world tomorrow in this most important observance. According to the WHO, close to 800,000 persons die due to suicide every year. That is equivalent to one person every 40 seconds. While there is no single reason why persons end their lives by suicide, this public health hazard affects every country, every ethnic group, every age group, every income group. Basically, it affects persons across the board. Although it affects both genders, more men die by suicide than women. May I have the first slide, please? This slide demonstrates that according to the WHO 2017 Global Burden of Disease Statistics, among children ages 5 to 14 years old, suicide ranks 14th as a cause of death. However, it is significant to note that for the 15 to 19-year age group, it is the third leading cause of death globally. And if we expand that age group to 15 to 29-year-olds, it becomes the second leading cause of death globally. May I have the second slide, please? As illustrated on this slide, the 2017 Global Burden of Disease Statistics for Trinidad and Tobago ranked suicide as the 6th leading cause of death for the entire 15 to 49-year age group. With those statistics in mind, it is important to note that for every person whose life ends by suicide, there are many more persons who attempt suicide every year. It is equally important to note that for every person whose life ends by suicide, there are innumerable persons whose lives are affected by the grief and trauma associated with that loss. There are no further slides. Almost 80% of suicides occur in the low and middle income countries, and the most common methods used include ingestion of toxic substances, frequently pesticides, hanging, and the use of firearms. Trinidad and Tobago's 2018 suicide rate of 12.9 per 100,000 population ranked 38th in the world and 6th in the region of the Americas, exceeding the global average of 10.5 per 100,000 and the regional average of 9.3 per 100,000 population. And that's according to WHO 2018 statistics. This indicates a significant need for comprehensive and sustainable intervention as a public health imperative. COVID-19 has further compounded this situation by producing a plethora of additional psychosocial stresses, which, if not adequately responded to, can increase levels of frustration and hopelessness and predispose even more persons to death by suicide. A greater focus on suicide prevention strategies is therefore imperative at this time. The theme for World Suicide Prevention Day 2020 is working together to prevent suicide. While some suicides are impulsive, suicide is generally preventable. However, suicide prevention requires everyone's input and demands a whole of government, whole of society approach. Intersectoral collaboration is critical for the success of suicide reduction strategies. Collaborators in suicide prevention must therefore include healthcare providers, mental health advocacy organizations, social services, emergency services, substance abuse services, employers, researchers, educators, legislators, faith community members and leaders, persons affected by suicidal behavior, and those who have engaged in suicidal behavior. These strategies include reducing access to means of suicide, responsible reporting by the media, school-based intervention, reducing harmful use of alcohol and other substances, effective, accessible mental health and substance abuse services in addition to general healthcare services, training non-specialized health workers in the assessment and management of suicidal behavior, and follow-up care as well as community support for persons who attempt suicide. It takes work to prevent suicide, but together we can make significant progress towards that goal. I therefore urge each and every one of you to spread awareness that suicide is preventable. Educate yourself and others about suicide prevention. Show compassion and care for persons in emotional distress. Challenge stigma around suicide and around help-seeking behavior, and share your own experiences if you have been affected by suicidal behavior. Let's all work together to prevent suicide. Thank you for your attention.
Thank you very much, Dr. Othello. And we are moving into the question and answer segment now. Our media representatives are asked to pose their questions to members of the panel, state their name and media house. Because our time is limited, we request a maximum of 2 questions per media house. We begin with Guardian Media Limited.
Hi, morning everyone. Rishard Khan, Guardian Media Limited. I have 2 questions this morning. Firstly, Minister Diyal Singh, I've seen on social media at least one advertisement from a contractor that they are doing COVID-19 sanitization. And I was wondering, for any companies or any of this sort who are doing sanitation for COVID-19, do they need to go through any sort of process through the ministry to get approval to do it? And with that in mind, I know there's one company for certain that the Ministry of Health is using at its hospitals and stuff. I don't want to call the name, but could you say how much has been paid to this company so far in our COVID-19 fight? And to Dr. Hines, on the last occasion of the press conference on Monday, I asked about the deaths that we've seen recently. And I asked how many of these persons died at hospital, if any died at home at all, and in what condition were they warded in when they died. But I didn't get a response then, so I'd like to ask that question again.
Okay, thank you, Rishard, for your questions. No company needs approval from the ministry to sanitize. That will be the height of micromanaging, which will actually slow down the sanitization process. I don't think any country in the world requires prior approval. There are standard chemicals to be used, from simple bleach and water. Dr. Rahman was here several times talking about the type of chemicals that can be used. So no company needs approval. How much has been spent to a particular company? I wouldn't have that figure off the top of my head. I will have to get that from North Central RHA, because they are the ones who will employ any contractor in the COVID fight. So I will ask them, and hopefully I can have that answer for you at a future date.
Okay, good morning. Thank you for your question. With regard to the deaths, the majority of the persons who have passed on in hospital care. I believe there may have been an incident or two, I'm not exactly sure, but we will verify and get back to you, where individuals may not have reached the hospital prior to having passed on, but they may have been tested or diagnosed somewhere within the time frame. The important thing about this is really that, again, because we're seeing the recurring pattern of individuals with pre-existing conditions and individuals in the older age brackets having the less favorable outcomes, we do again want to encourage that if you have respiratory illness, if you're beginning to have any worsening of your symptoms, that we do not base your decision to seek care or to go to a facility strictly on the basis of whether you know your COVID-19 result or not, or on the basis of whether you can reach out to the individuals who may have been in contact with you previously. If symptoms are worsening, the best thing to do would be to contact the emergency services, who can take you through the appropriate channels for seeking urgent care and the protection of all individuals, including the patient, is ensured by the quick access to a standardized channel for care, which is the emergency service. So please don't hesitate to use that while either awaiting a result or waiting the system to contact you once more if they were following you up before. Those are the sorts of things we'd like to avoid. And again, seeking care early in the trajectory of your symptoms rather than late is what we advise for anybody who has pre-existing conditions or the persons in older age groups.
Before we go to the next question, because Rishard has hit on an important topic, I just want to reiterate what Dr. Janine St. Bernard said here a couple of weeks ago. Dr. St. Bernard said clearly, persons who are self-isolating, when they are called, you are to be truthful with the doctors that call you about your symptoms. Because what she noticed is that when you talk to the patient, you get one story, but then when you talk to the family members, you get a different story. So there's a strong sense of responsibility now, as we are not hospitalizing everyone, which has gone down well. People were asking for this, that you be totally honest with the doctors that call you twice a day. And if you are not feeling well, if you are feeling worse, Dr. St. Bernard said, if you feel your pulse is racing, you are having trouble to breathe, stand up, don't downplay it. Because she has said clearly, when you speak to the family members, you get a different version than when you speak to the actual patient. So Rishard has raised an absolutely vital point here. Thank you.
Thank you very much. And now we move to 91.9.
Hello, good morning. We're next to 91.9. Good morning, Minister and the panel, Dr. Otello and Dr. Hines. This question, I hope you can give some answer to, but I think it's where we are at now in the pandemic. What is the government's position, Minister, in terms of preparing the country for living with COVID-19? As you continue to see people not responding positively to some of the measures, people still getting ticketed for not wearing masks and so on. It seems as though in this second phase, we have not seen a particular slowing as yet. And Dr. Hines, you could probably speak to whether we are looking for a third phase, or are we looking into moving into living with COVID-19? And, you know, what would that mean for the health ministry moving forward? If you could answer those, I'll be appreciated. Good morning.
Thank you. So we have said clearly, and I want to echo the Honorable Prime Minister and myself. We have been saying clearly ad nauseum, we have to learn to live with the virus. Not only Trinidad and Tobago, because I think sometimes we feel this is a Trinidad and Tobago thing. This is a global, the world has to learn to live with the virus. The world has to learn to adapt and change its behavior and its expectations of what life is going to be. For this generation, this is what people who lived through World War II had to do. For 7 years of World War II. You lived through World War I, you had to go through this. 9/11, you have to go through this. The 1918 flu pandemic, you had to change. This is our World War I, our World War II. And have to change because the virus shows no hint of going away. The global number of cases, as I said before, what did I say they were at? Seems to be consistently high. Let me just give you the figure again. It's about 3,000. Right, I have it here. It's about 275, 250, 300,000 cases per day, and it has been averaging that since June. We started to hit 300,000 cases a day since June. We are now in September. So we have to learn to live with the virus. The game changer for this will be a vaccine. When we will get a vaccine that is safe and effective, that has gone through all phases, especially phase 3 clinical trials, the cautiously optimistic say early 2021, we wait and see. The virus sets the agenda. The virus sets the agenda on this. So it's going to be a continuous program of giving information, guidance, legislation, and unfortunately now law enforcement. Because as you have rightly said, there are still some pockets of people who don't get the message and who will only respond to police enforcement. That is regrettable. But for those individuals and those sectors of society that don't want to voluntarily cooperate, that has to be done. I'll give you an example. I left here Monday after the press conference. And I'm so sorry to have to say it, but I have to say it. I went to purchase lunch. And you know what I saw? Someone in full view of the public with their mask down eating lunch on the premises. It is clearly against the public health regulations for in-store dining. How do you legislate again for that? In full view of the owner, in full view of the public, in full view of everyone. What else can we do for those persons who are hell-bent on crashing the system? Let me stop there. I was so bitterly disappointed in that establishment. Bitterly disappointed. We tell people no in-store dining. Keep your business going with takeout. We know what is happening in the bars. In some bars, not all, some are being responsible. You saw the front page of the Express today. People have to work with us to understand we have to live with the virus and change our lives to suit. Thank you very much.
And to answer the second part of the question with regard to the whether there'll be a third wave or third phase, what you see with global pandemics is that there's a series of ups and downs. The first experience that our population had was where we had sporadic cases and managed with the interventions not to get into the community spread phase at that point in time. The second experience has been more in line with the global experience of having community spread established, as it has been in most countries in the world. And at that juncture, all that happens is that you implement measures to slow, you get some slowing, you may release measures, you may get some increases. You've seen it happen in Australia, New Zealand, and other places where there's going to be a waxing and waning of measures, cases, and this will eventually diminish with time. But in the intervening period, to echo the minister's sentiments, what we need to do is take all of the precautions necessary to live with the virus and to conduct our life's activities in spite of the ongoing risk with the highest level of precaution that we can manage and maintain. Ms. Alcantara?
Thank you very much, Dr. Hines. And AZP News, we're ready for your questions now, please.
Hi, good morning. Priya Bihari, azpnews.com. I have two questions. First one deals with the number of beds available in the ICU at Kuva and at Kora. Can you let us know how many beds are there? Because recently we have seen that there was a maximum of 6 people at a time in ICU. I'm just asking if there's a problem with people moving from the HDU into the ICU because of the lack of numbers of beds. One. And my second question.
Sorry.
Has to do with horse racing, Mr. Minister. Why was horse racing allowed to take place when other sports were banned and not allowed to take place? Those are my questions. Thank you.
So, on the issue of horse racing, I think when I read the regulations, I think the regulations spoke about contact sport. So I don't know if horse racing qualifies as a contact sport, but we could clarify that. On the issue of HDU and ICU capacity, at Cora, I'm looking for the exact figures here. The Cuva facility, we had started off there activating the pediatric tower. We took a decision recently to activate the adult tower. That has been done. In Cora, many months ago, we took a decision to convert the 4 isolation spaces there into ICU. So you have 4 there. Then you have ICU capacity at Arima. I'm trying to look for the numbers here. And then you also have ICU capacity at Pointe-a-Pierre. So in terms of ICU, HDU capacity, we are well served. If I get the exact numbers, I will give it to you in a subsequent question and answer period here.
Thank you very much. And we go to AZP News. Oh no, we just did AZP. My apologies. 98.1, please.
And good morning again to the panel. Stephen Cummings, 98.1 FM. I would address my 2 questions. One for Dr. Othello and the other to Dr. Hines. Dr. Hines, I start with you. You spoke on the last occasion of the vulnerability of densely populated areas in the country in terms of residency. Is it that the ministry now has a special focus on densely populated communities rather than the movement or behavior of people across communities? And Dr. Othello, there is little data yet on the COVID-19 pandemic and its impact on suicide rates or even families who have so far lost relatives during this period. But clearly the pandemic has added intense emotional and mental stress to the lives of people around the world. Is it that we in Trinidad and Tobago and from your office, we could see some kind of official monitoring or reporting along with the necessary prescriptive measures where needed in treating with people? Thank you.
Thank you very much. First question to Dr. Hines.
Thank you for your question, Mr. Cummings. When we spoke about the geographic distribution of the cases on Monday, we were not speaking about specific vulnerability based on your geographic location, but we were speaking about the fact that the density of the population drove the distribution of cases, and we summarized that by saying where there are people, there are cases. The population density really refers to the number of people within a given square area, whether it is square mileage, square kilometers, etc. And we do see that the pattern of distribution of the largest number of cases is found where the population densities are shown by the maps on Monday, where the population densities are greatest. But the approach to reducing the risk for spread, as you correctly alluded to, is not a matter of looking at the population density, but looking at individual behaviors and attempting to get collective population behavior to reduce risk by taking all of the necessary precautions. So there isn't going to be a specific geographic focus. What we need is individual responsibility to amount to behaviors that lead to good collective outcomes.
Okay, so I do have some additional information. I'm reading a reply which is a few days old, so the numbers may be a bit off. This is from the CEO of North Central, Mr. Davlin Thomas. The ICU at the pediatric tower of Cuva is filled. However, there is additional capacity at AREMA, as we said, and AREMA is currently treating ICU. And the adult tower at Cuva is also currently treating ICU patients. So there is no shortage of either ICU or HDU capacity. We have capacity at both towers at Cuva, AREMA, and Point Fortin, and Cora with 4. Thank you very much.
Thank you very much. And now to Dr. Othello for the second question.
Thank you for your question, Mr. Cummings. The Ministry of Health has in fact recently completed a national suicide prevention strategy, and this strategy will be rolled out in the coming months. However, what it aims to do is to reduce the rate of suicide in Trinidad and Tobago by 10% over 5 years as part of a national response to suicide, which will be implemented in 5-year phases. So that's only the aim for the first 5 years. What we're looking at is producing mechanisms for proper monitoring of suicide statistics, as well as addressing specific high-risk groups and meeting their needs efficiently, and reducing the risk factors that predispose persons towards suicidal behavior. So the ministry is in fact looking at that. We are aware that the current scenario increases stress, increases hopelessness in some persons, and we are aware that we have to have an excellent response to that. In addition to the Ministry of Health, there is also research going on by several persons at the University of the West Indies that's also looking at the mental health impact of COVID-19. So I hope that answers your question.
Thank you, Dr. Othello. And we move now to I-95.5.
Good morning to everyone. Whithfield Turner from I-95.5. Dr. Othello, I just want to follow up on Stephen's last question. Is your department sufficiently staffed and resourced to adequately address the likely upsurge in mental health needs during this particular pandemic period that we are in? And for Minister Dayal Singh, we now have a situation where certain classes of persons are being asked to supply a negative COVID-19 test within 72 hours of their scheduled arrival into the country. In the event that there is some unforeseen delay due to no fault of theirs, they are asking whether that PCR test would still be acknowledged, or what would happen if they are now outside of that 72-hour period coming into the country. Thank you.
So you asked, just repeat briefly the question you were asking about the returning nationals and PCR tests. I didn't really get the gist of I just want to make sure I'm accurate. Briefly.
Right. Now persons are being asked, certain classes of persons would now have to supply a negative PCR test before coming into the country. And they are trying to find out if something should happen on their way here that puts them outside of that 72-hour window. What happens to the test results? Is it going to be honored still?
Dr. Hines, you're the technician here.
Okay, so if I understand the question correctly, saying the person did get their result within the 72-hour period, but then were further delayed by circumstances beyond their control, will that negative PCR result be acknowledged? And the answer to that would generally be yes, but it would still be assessed on a case-by-case basis.
Okay.
So it will be reviewed, the information will be checked, but under normal circumstances, we would think that we would be able to accommodate that because we'd need to retest when they arrive in any case. But that can be further updated by the CMO when he next presents on that repatriation process.
And that is something to be worked out between the CMO and the Ministry of National Security. I wouldn't like to speak out of turn on these matters.
Okay, and now to Dr. Othello, please, for the first question, for response to the first question.
Good morning, Mr. Turner, and thank you for your question. With respect to you said my department, so I'm assuming that you mean the mental health unit in the Ministry of Health. We are predominantly a department that focuses on policy development and technical support rather than the operational side of the mental health services. So that the operational side, in terms of responding to the needs of persons who may be contemplating suicidal behavior or their families or loved ones, that within the Ministry of Health rests within the RHAs. There are mental health services, as I described before, that are provided across Trinidad and Tobago by all the RHAs, and that's the place where someone is needing to seek help for be it depression or anxiety or any other mental health disorder or any other situation that can increase their risk for attempting or, God forbid, completing suicide. You would be encouraged to seek help at one of the RHA facilities. In addition to that, there is also the helpline Lifeline, which provides human service to persons who need a listening ear, and they are available 24 hours a day.
Thank you very much, Dr. Othello. And now to Loop TT, please.
Good morning, everyone. Nneka Parsanlal here from Loop TT. I have two questions. I'd just like to find out a bit about the protocols we have in place for inpatients at the St. Anne's Mental Hospital. I think it's a bit important to touch on how they're treated if found to be COVID positive within the context of an existing mental health issue. And my second question, is the public health sector making any provisions for people who need PCR tests for leaving Trinidad and Tobago? I know we had a situation where our country's policy changed a bit quickly, and so our authorities really couldn't help at that time, but has anything changed since then?
So I will let Dr. Othello deal with the first issue, but as the Minister of Health, we are instituting a parallel system to accommodate mental health patients who are COVID positive. I had that conversation yesterday with the CEO of Northwest RHA and the CEO of Southwest RHA this morning. So we are setting up under the auspices of Northwest RHA a facility to accommodate just that. Dr. Othello could tell you more directly about the care of mental health patients who are COVID positive.
Okay, at the St. Anne's Hospital, what has been set up has been a system where new persons being admitted are all taken to one area of the hospital rather than sent to the individual wards, so that they are screened before they go to that ward, and persons stay in that ward for a period of 14 days before they go to the other wards. So that is intended so that if somebody who is admitted starts to present with flu-like symptoms, they can be tested and managed and all of that, rather than going to the other wards and contaminating, or, well, I don't like to use the word contaminating, but increasing the risk for transmission to patients in other wards. With respect to the additional measures being put in place, I myself am in the process of catching up with the details of that. So that question would have to be answered at another time.
And let me just go back to the other part of Nneka's question to me. The issue of nationals going to Barbados. They can take advantage, and I'm being told on the ministry's website, where they can be directed to get their PCR tests in the private sector. Thank you very much.
Thank you very much. And questions now from CL Communications, please. Wonderful. CL Communications?
I have a very small question. Looking specifically at the front story of one of the newspaper, where you're seeing this group of people, even though it's a private development, you see that the residents were trying to alert the police, and the police didn't even swoop down until it was like very late. I was just wondering if this situation has grabbed the attention of the ministry, and if anything is going to be done to send like probably a little written warning to those residents. And then the second question, I'm not sure whether the minister had addressed this before, but the issue of the backlog of the COVID tests and the results to come out from Tobago, I think mention was made of that backlog. And I was wondering if anything was done to clear that backlog.
Thank
Thanks.
you. So I had a conversation with both the Commissioner of Police and the Minister of National Security this morning on that same issue. And I think the regulations more or less speak to public spaces. But over and beyond that, I have been imploring and sometimes literally begging people not to host these type of events in your private properties. Now, I will have to talk to the Attorney General to see if it is possible, because these are serious constitutional areas we are going into now. People have a right to privacy. It's in the Constitution. But we don't need a constitutional argument to tell people that how you conduct yourselves in your private premises will capsize the whole thing. Do we need to go that route? Do we really need to do that? In the face of all the evidence that is out there, in the face of all the evidence that young people are driving this second wave, and you will feel well, you will recover, but you take the virus home and you infect your parents, you infect granny, grandpa, and they die. They die. Now, I understand. I was young at one time. I wasn't born at age 63. I was born at 0, and I had an active social life at that age. I understand that young people in their 20s, 30s, and 40s want to lead an active social life. I didn't have to go through that at your age. But this is our World War II. And it is going to call for all of us to be responsible. From captain to cook, the poor to the rich. Each group, each political party, each place of worship, each demographic. I deliberately did mention that express photograph in my opening statements. Normally I do it, but I was so, like how I was disturbed when I went to lunch on Monday and saw a man dining in full view of everyone, totally unconcerned. That is what will capsize the system. So you pass the regulation, no in-store dining, but it is being flouted. Now we have to go into people's private homes and tell you how you have to behave. Shouldn't have to be. So the backlog we have cleared up. I was told this morning in our meeting, we have cleared up 700 of the backlog, and we continue to work on it. Thank you very much.
Thank you, Minister. And now, Power 102, please pose your questions.
Good morning, Minister. Head table.
Good morning.
Power 102 FM. Minister, my question this morning is about vaccines. There was an article published on CNN this morning where I think it was AstraZeneca. They actually paused trials on their, I think it's Oxford vaccine, because one of the volunteers got ill because of the vaccine. And so I know that last month, I think the ministry was invited to a meeting about vaccines, well, VCVs on the whole. And Minister, I wanted to know if there was an update on that meeting in terms of vaccines. Is the fact that AstraZeneca has paused their trial testing, will that affect us here in TNT? Yes. Although I know that we're going through PAHO and COVAX for our vaccines in Trinidad. Thanks.
Thank you very, very much. So it is not unusual for any phase 3 trial involving 20, 30,000 persons to have an adverse effect. As a matter of fact, it's a miracle they didn't have more. However, because of the pace vaccines are being developed, this does present as a roadblock to that particular vaccine. We in Trinidad have signed up to the COVAX protocols, and we are following the COVAX protocols, where once a vaccine is developed, this COVAX thing works like a mutual fund. You go to Unitrust, you deposit your money, Unitrust distributes it against a range of stocks. You don't know which stock. Similarly with COVAX, we buy into this, PAHO invests it in a portfolio of vaccines in trial. Whichever one comes out the best, we access that. How we are going to distribute these vaccines, when and if we get it, is going to be for healthcare workers first, the vulnerable groups in parallel. So the elderlies who carry the brunt of the disease by dying, between them and healthcare workers, they get first access. We have ordered, I believe, on paper, about 400,000 doses of the vaccine. But any country going into the COVAX facility signs on knowing you don't get all 400,000 at the same time, because we don't know if the global supply can accommodate what every country wants. What we have signed up for with COVAX is that we will get in the first instance 20% of what we need. So 20% of roughly 400,000 is 80,000. That will help us in the first instance, in the first few months of the vaccination process, to vaccinate hopefully every single healthcare worker. There are about 17,000. Starting, of course, with frontline, your nurses, your doctors, your A&E people, your ambulance drivers, and then you work your way down. And then we will try to vaccinate at the same time our elderly who carry the brunt of the mortality and morbidity of this disease. So that is where we are with our vaccine program. Does the AstraZeneca one affect us? We don't know, because PAHO invests in a portfolio of vaccine developers around the world. Thank you very much.
Thank you. And now to TTT, please.
Hello, good morning. Sonal Lala, TTT News. Minister, I know we've seen an increase in deaths in Trinidad and Tobago. Has the ministry done any assessment as to why the majority of deaths have come from elderly males? Has any assessment been done?
Yeah. So that assessment was known months ago.